make sure I'm recording. And we were on slide 40. We did 43, so 44. Okay, so we were talking about absorption and the pH of the environment and how the pH affects the absorption of the medication. And that's all based on lipid solubility. Like if most medications, most things have to pass through cells, they have to sort of be similar to that cell membrane, and the cell membrane is lipids. So that's why a lot of medications, and sometimes it's the size of the molecule too, but that's why a lot of medications will go through the cell membrane, is because they're able to penetrate that lipid bilayer. So that's kind of where we left off. There was no questions on that for the quiz. So the next quiz will be some of the rest of this content, and then the autonomic nervous system, which is what we'll talk about next. So that'll be, I think that's the quiz for next week, and it'll be a little harder because this quiz was a little fluffy. It had a lot of questions on, like naming of drugs and stuff. So, but I was just easing you into it. So it's like a little bit of a. I know.
Thank you. I appreciate that.
I know. Sometimes my multiple choice, I just get caught in like just saying something funny instead of trying to make it like a really hard question. And I'm just entertaining myself, and I apologize if I'm like making it not professional enough, but it gives me a giggle when I write it. And then I'm like, why did I do that afterwards? But oh well. Okay. Okay, so the next part. So when we were talking about drugs, we were talking about those four. We'll flash back here to those four. The absorption. Yes, ADME. So that's where we're in, just to give a recap. So we're still in pharmacokinetics. We're talking about how drugs move around the body. And we basically just talked about absorption. And so now we're going to talk, the other ones absorption tends to be the bulk of the conversation. The other ones, you don't have to know quite as much, although with distribution, there is a few key things that you need to remember. But absorption is kind of like the big one, because it talks about, being in the same environment, the pH matching up. If it's a weak acid, it'll absorb better in a weak acid environment, and so forth. So that one has a little bit more content. Distribution has a few key points, and then metabolism and excretion, we don't really go in deep into those. I mean, they're probably much more complicated than what we talk about, but it's pretty limited to what we talk about. So so the next one, so distribution. So distribution, so once a drug has gone through the cell membrane and now it's in the bloodstream, now it's in the circulatory system, and it's going to exist in the blood, either bound to a protein, or it's just going to be free floating. So some key points that you have to know about that is that's how it'll exist as it's going around the body, either bound up to protein, which it's usually albumin, usually albumin, or it's just free floating. And so the biggest thing about those two aspects is if it's bound, it's pretty much inactive. So if a drug is highly protein bound, or a highly bound drug, and there's just a little bit of drug that's free floating, then it's not a very potent drug. Like most of it's, the body's just like captured it and it's not letting it do anything. Sometimes, and we'll talk more about how that can be affected too when somebody takes multiple drugs at the same time, or diet, something you eat could sort of take up that drug. So you only have those two as far as we're going to discuss it, like there's probably more to it. You only have those two states, either bound to a protein or free floating. If it's free floating, it's available for the body. If it's bound, it's not available. Yes.
This says they're bound reversibly. Does that mean they can become free after they're bound?
Yeah, so I think at some point, and there's probably a lot more to that. I kind of just leave that a little bit vague. There's probably a lot more to that, but potentially during time they could release from the protein and then they could slowly become available. But I'm not sure about the timing of that, and I'm not going to quiz you on that. So the textbook might go into it more too. I don't know, but I'm not going to quiz you heavily on that. Okay. Those are always kind of really good questions when we have our guest speakers come in, that kind of stuff. They usually know exactly, and then they can enlighten to like why medications, like if you take one medication that's bound and then you take another one on top of it, but then if it is releasing off of the protein, you might get a spike of the second medication, you know, without planning it. So they have to kind of know that. The pharmacist has to know that and how those drugs are going to react. So those are great questions for the pharmacist when they come and talk to us. Okay, so if a drug is highly protein bound, will it require a higher or a lower dose of the drug to have an effect? So if it's highly protein bound, would you need a higher dose or a lower dose? Yeah, you'd need a higher dose. And then I kind of already said this a second ago, but what else can affect if a drug is protein bound? What else could possibly affect it? Food, yeah, food. So like milk or grapefruit. So there's enzymes in our livers that that sort of metabolize these drugs as well. And so that can affect it as well. So like if there's a grapefruit takes up these enzymes or does something with the enzymes, and so it makes far more drug available. So sometimes it happens in other parts of the body too, but this we're specifically sort of just talking about in the circulatory system. But yeah, food and then other medications as well. So then metabolism, which is also called biotransformation, that's when the medication comes into the liver, and then the liver, there's a lot of enzymes that have different interactions with the drugs, and they turn some of those some of the dosage of the drug into metabolites. And once that drug has become a metabolite, you might remember from the video that we watched last week, it's just no longer available. It's not the right shape. It's not going to match up to the receptors. It might not do anything to the body at all anymore once it's been changed. And so then it just kind of gets through your system as sort of a waste product, and then you'll eventually excrete it. So every time a drug makes this cycle over and over and over again, more and more of the drug will turn into a metabolite. And that is also affected by the number of enzymes in a person's liver. So if somebody is, you know, maybe sicker or more immune compromised or just has systemic diseases, they're going to metabolize a drug differently. Children metabolize drugs differently. And then again, this is a better time to give the grapefruit example. Things you eat can affect enzymes as well, which will affect how a drug is metabolized. So the body changes the drug from the lipid soluble form to a more water soluble form. And then we know from the absorption part that it's not going to be absorbed as easily. So it'll just more easily go through the body and be excreted. And then most drugs are metabolized into an inactive metabolite. Like we said, metabolites convert the drugs to a water soluble form. We already said that. And this all takes place in the liver. So make sure that you highlight liver. That'll be a question. Where does metabolite biotransformation or drug metabolism, where does that take place? And it's the liver. It can also happen to some degree in these other places, but predominantly you want to know that it happens in the liver. So here's just a little example. This is showing like sort of a balanced, the top picture here is sort of a balance. You have a kind of a predictable number of enzymes in your liver. The doctor prescribes you a predictable kind of typical dose, and then you end up with sort of a predictable amount of metabolites that will, you know, keep cycling through, and the drug will kind of have a more predictable route that they are accustomed to, and they can, you know, limited adverse effects. But if somebody has far more enzymes in their liver, then they're just going to metabolize it more and they're going to go through the drug. The drug's not going to have as big of an effect on their body. They may need a higher dose. And then if they have far less enzymes in their liver, then the opposite's going to happen. A regular dose might end up being far more potent than they actually need, and it could cause some kind of an adverse reaction because they just have more of the drug in their system. Yes.
So once you, like, abuse the drug, so would their body just have more enzymes and that's why they.
Oh, like building up a tolerance?
Yeah,
Oh gosh, that's a great question.
then like maybe they're not having more.
Yeah, I don't know. That's such a good question. I'm gonna have to look that up, or somebody can look it up through the class. Because if you're building up a tolerance to a drug, I mean, we always just say like, oh, your body gets used to it. But on a chemical level, is it because they're building up the ability? I don't know. That's great. I can't even speculate. Maybe I've known the answer at one point, but I don't remember it now. So I'm gonna have to look that up because that's a great question. Okay, and then excretion, most drugs leave by way of the kidney. So when you remember this stuff, remember it metabolizes in the liver and it is excreted through the kidneys. And there are a few other organs where that some of the drug can be excreted, but in general, it gets excreted through. And there's not much more that we're going to focus on when it comes to excretion. The main thing is knowing those four terms and in general, what's happening in those 4 stages. And then what we focused on, but we don't go into big depth here with that excretion. Okay, so that's it with pharmacokinetics. So we finished that term. So knowing that terminology and those 4 stages. And so now we'll talk about the biologic half-life. So every drug has sort of a predictable amount of time that it takes for the drug to metabolize and get through your system, so that if you've broken your leg or you've had some major surgery and you're going to be on some kind of a prescription pain medication, they'll say take this drug every 4 hours or take this drug every 8 hours or whatever it is. And they know that a certain amount of the drug is going to be through your system, so you want to load another dose before you totally run out. So they know the half-life of these drugs so that they can keep you on a good regimen. So it's the time required for concentration of the drug to be halved after absorption is totally complete. And it just keeps cycling through. So once it's kind of gone through that first cycle, how long does it take for the dosage in your system to be half of what you originally took? So an easy one to use is Tylenol, something over the counter, like could easily swap in something like ibuprofen. But if you take 500 milligrams of Tylenol at noon, the half-life, which is written T half, is 2 hours. So in 2 hours, you're going to go from 500 milligrams to 250 milligrams. And then 2 hours after that, it's half of 250. 2 hours after that, it's half of 125, and so forth until you don't have any more drug in your system. So it just halves whatever was the last number. And yeah.
The 2 hours, you split that up. How do you get 2 hours?
Well, like, how would you know the half-life? I don't know that the half-life is on the label at all. I don't know, that's a great question. Like, if we looked up Tylenol, I don't know if Tylenol says Tylenol's half-life is 2 hours. They just end up for consumers and for patients. I think they end up transferring it to take this drug every 4 hours, because they know that in 2 hours, half of it's going to be gone. So then 2 hours after that, you're going to be down to like a fourth or whatever. So I think they transfer that. So that is, again, this is really important information for the pharmacist to know when they're prescribing medications. And it's good for you to understand this background information, but it might not be like on a bottle of Tylenol. Other interesting things where this plays a role is drugs like bisphosphonates, which can be given orally, or they can be given through IV. They're given to patients who have osteoporosis, or they're given to patients who have cancer to sort of capture excess calcium. Bisphosphonates have a half-life of like 10 years. or something. Like once you take it, it's like in your body for a very long time. So, and that has, we'll talk about that in another chat in another lesson, but those are, it's sort of like, it plays into more your professional knowledge more than necessarily a consumer or a patient knowledge. Okay. Pharmacodynamics is the next one. Actions of drugs on the body. So how the drug is affecting the body. What's the drug doing to the body? And it involves the receptors, the receptors that take the molecules of the drug and that drug molecule does something to the receptor. It either makes it do more of what it naturally does, or it blocks it from doing what it naturally does. That's pretty much all the options there are. It either makes it do more or makes it do less. That's pretty much all a drug can do to a receptor. So the drug, we'll talk about the drug receptors and their interactions, the mechanism of action, and then the dose response relationship. And there's a lot of terms that are sort of, can easily get sort of jumbled up and sound the same and get a little confusing. But okay, so drug action. So we have the receptor sites in our bodies. We have receptor sites on different tissue, on different organs. So like your brain or your, you know, your whatever, your heart or your lungs or your gallbladder or your pancreas, whatever. And so the receptors will bind either a drug, so the medication that you've taken, or an endogenous substance. And an endogenous substance basically just means something that your body makes. So an endogenous substance can be epinephrine. Our body makes epinephrine. So a hormone or a neurotransmitter. Those are things. So if it's endogenous, it's just your body makes it. So the receptors will bind either what it kind of normally wants to bind, which is an endogenous substance, or it'll bind the drug, this drug molecule that you've ingested. And the action of the drug will basically breaks down into these three parts. It'll either be an agonist, which means that the drug binds to the receptor and it produces an effect. So it's going to make that receptor do more of what it normally would do. So, you know, if somebody has, this is not very common. The medication that they use for this is weird and you won't hear of it very much, but they do have medications that like help patients with dry mouth. It like produces more saliva, but it's a weird drug but this just came to mind. So I'm just thinking like if your saliva glands aren't producing enough saliva, then the drug molecule is an agonist to those receptors to help kick up the saliva production. Or you can think of also like insulin, drugs that work on the pancreas to help the pancreas with insulin production. So an antagonist is drugs that bind with a receptor, but they are blocking an effect. So they're a different shape and they just kind of gum it up and they don't allow the endogenous substances to come and do what they would do. So they just don't allow, they take up space and they don't allow your body's natural neurotransmitters or hormones or whatever to do what they would do. And then there's partial agonists. So they're kind of like weaker. They'll bind and have a milder effect. So they're kind of like a partial agonist. Yeah. Yeah, so some of them are inhibitors. So like SSRIs, they're like reuptake inhibitors. So that is an I don't know what you're giggling at. I'm assuming it's my face. I don't know. But they're so a lot of times you can tell by if it says inhibitor or not. So like a beta blocker, it's blocking, so then it's an antagonist. So different medications do different things. And so within anti-anxiety medications and within depression medications, they can do both. It kind of depends. And we have a whole thing on those. Because there's all, and talks a lot about the neurotransmitters, because a lot of times they're blocking the ganglion from taking up the neurotransmitter. So the neurotransmitter is hovering in this synaptic space. And so it's technically, I guess it's blocking something. So I don't know. We talk about it later, but it's very interesting. Okay, so here you can just see it's like the molecule fits in the receptor. Doesn't fit in the receptor, that's the agonist. And then I guess that's a partial agonist. I don't really know this animation. And then it circles antagonist. I don't understand what that's doing, but anyway. But you can see the one that fit really well is probably the agonist because it fits, it's going to make it do what it's going to do. And here's just another little demonstration as well. Here you can either have, so you can have the neurotransmitter or a hormone. This is endogenous into the receptor site. So it fits like a lock and key. And that's what your body naturally does. It releases some hormone to have some effect, and that's what your body's supposed to do. And then if you have a drug that's supposed to do something similar, it'll fit similarly into that receptor site. The receptor site was like, oh yeah, I can utilize this. And that's why the drug has that effect. But if it's a blocker of some kind or an antagonist, it doesn't fit into the receptor site, it just blocks it.
So would be the partial?
I kind of feel like, I think this one is demonstrating like your body and then an agonist. So I don't think this one actually has a partial on it. I think the first one is just trying to show like what your body would normally do. And then the next one is, even though it's not filling up the receptor site, I kind of think it's, but maybe it is, I don't know. We'll just call it just a full agonist because that's what it says there. So we'll just call it a full agonist. If it fits into the receptor. Like a weaker effect? That's a good question. What would be a partial agonist? You guys ask such good questions. What is it? Maybe what? Maybe vitamins? No. I don't know. Good question. Where's my blank piece of paper so I can write down your excellent questions? An example of a partial agonist. I want to know these answers. Is antihistamine? Yeah, there's mast cell blockers. There could be, so sometimes, yeah, if you have too much histamine and your body's like going crazy, then that's what you're trying to do is like dampen the effect. And we talk about that next. Oh, no, that's in respiratory. That's when we talk about rhinitis and respiratory diseases, asthma and things like that. A partial agonist. Tramadol is a partial agonist? And dopamine is a partial agonist, is what they say. Interesting. You guys will never be tested on that. So feel free to fill your mind with interesting facts, but it's not going to be on an exam. Partial agonist. Yes, exactly. And we do talk about dopamine because dopamine cannot cross the blood-brain barrier. So it needs a carrier. It needs something to help it. So a lot of times if somebody needs more dopamine, then they take dopamine and carbidopa. They take levonorepinephrine, or no, that's the thyroid. But they take a carrier to help it get across the blood-brain barrier. So that kind of makes sense actually, because it can't have as strong an effect. Dopamine just can't have an effect by itself. So that actually makes a lot of sense to me. That's interesting. Yes. Oh, it's a major antagonist. Yeah. Yeah. No, it's a major blocker. Yeah. Yes, but it's very short. It has an incredibly short half-life, right? Because you'd have to take Narcan like over and over and over again if you had a major OD. So, oh, well, by that time they're in the hospital and they can give them hopefully, and they can give them an IV. Okay, so here's just another example. There's lots of picture things. I'm going to move on from there. Okay, so drug effects. Okay, we got to keep moving, you guys. There's tons of content, so we got to keep moving. So therapeutic effect, that is just basically these are a lot of terms that you guys are just going to have to memorize. So therapeutic effect is the clinically desirable effect. So if you have high blood pressure, the therapeutic effect should be that it lowers your blood pressure. So it's a clinical desirable effect. The doctor is going to see a benefit. Your blood glucose is going to be lower. Your blood pressure is going to be lower. Your heart is going to be contracting harder. So these are all clinically desirable effects. Oops, I went too fast. An adverse drug event, or an ADE, this has some specifics to it. It's undesirable side effects associated with the use of a medical product. It's unfavorable, unintended response to a drug, and it's usually a big deal. So this is not like a side effect. This is not like it gave me a rash, or it made me, my mouth dry. It's like, this is like a big deal. So it's life-threatening. It might cause disability. It could cause death. And partly this is preventable. It could have been preventable. Like maybe the doctor like had an oopsie doopsie moment and wrote you the wrong prescription and gave like way too high of a dosage. And so it can, it can be a preventable error. Like they gave you the wrong medicine, they gave you the wrong dosage. So medication error or an unpredicted response. So if it's an unpredicted response, that's really not super preventable, really. Sometimes people have just genetic factors and they'll respond to a drug completely differently. But in general, an adverse drug event, think sort of like think bigger deal, like not so much like an allergy or an allergic reaction or a side effect or something, but like a more like life-threatening or like a bigger deal. A toxic reaction is permanent damage to cells or tissue, too much of the desired effect of the medication. So that could happen, like if say somebody's seeing a cardiologist and then they're seeing somebody else, an oncologist or something, and they're not communicating and they prescribe medications that interact poorly, they could get a toxic reaction because of that, or they could end up dosing themselves too high. We had a medical emergency in here a couple, like not that long ago, just, was it this semester? Or was it the end of last semester? I don't even remember anymore. But it was an older gentleman who he came in and his blood sugar had been too high in the past. And the hygienist was like, we're not going to be able to see you if your blood sugar is this high. So he like went home and took like double the insulin, and then he didn't need anything. And so, so he had, like a toxic, well, that's a little different. That's probably not a great example really, because that's just, too much of something in his body. But it was very, it was essentially toxic because he didn't have enough glucose for his cells to function, right? So he's going hypoglycemic, which is one of the most common medical emergencies for diabetics. FYI, you'll need to know that. And then there's side effects. So that is usually dose related. Sometimes they can adjust your dosage and get rid of a side effect. That sometimes it's playing with the dose, not part of the desired effect. Sometimes you just have to deal with it. Drugs are not always selective to specific receptors. Sometimes it's like, well, I kind of work on this receptor and I kind of work on that one, but I'm really meant for this one. And so if you have that kind of a drug, then you're going to have side effects. So that's where side effects come from. Side effects and adverse reactions can be okay, so the event word is the different word here. So an adverse reaction can be similar to a side effect, but it's not an adverse drug event, which was on the previous slide. And then an example of that could be like GI issues with ibuprofen. There can be bleeding and irritation in the GI system. Allergic reactions, antibodies get sensitized to the antigen that enters the body, and then it might get sensitized the first time, and then when you take it the next time, your body's like, holy moly, I know what that is, and it goes crazy, and then you go into an anaphylactic type situation. You can have a rash or anaphylactic shock. And then those are not usually predictable or dose related. So if somebody has a true allergy, like not just a sensitivity, that gives me a stomach ache, I throw up when I take, Percodan, or those aren't allergies. Those are more like side effects / sort of reactions. A true allergy, you could have like a teeny tiny itsy bitsy bit of penicillin and it could throw you into a anaphylactic shock, like, a scraping of the pill, and it could still throw you into the anaphylactic shock. If it's idiosyncratic, it's unexplained, it's uncharacteristic. It could have to do with a hereditary factor or a genetic difference in somebody that's just totally unpredictable that they would never have known. So like there could be a drug that, you know, everybody can take just fine. And then all of a sudden somebody has some wild reaction to it just because of their unique, you know, genetic makeup. And then teratogenic effects, those are things that affect the fetus when a woman's pregnant, the baby. And so there's a list of medications and stuff that they know not to take. And they learn as they go because, you know, they're always creating medications and you can't test medications on pregnant women. Like you know, no pregnant woman's going to sign up to test some experimental medication. And so they learn these things sometimes, you know, a lot of times through animal testing, but sometimes they learn them because of unfortunate situations where they get enough, you know, effects on a baby, and then they're like, oh, and then they'll pull it, or they'll put a schedule, they'll put a category to it so that it's not prescribed to pregnant women. So here's just a little bit of a breakdown. These are all adverse reactions. They're not classified under an adverse event. These are all just classified under reactions. These are the categories for pregnancy. I don't know where this is, and I won't test you on it where they're at, but they were going to update all labeling and like get rid of the categories and update their system. But like a couple of years ago, they said it was going to take a while, and I don't know that they've still even done it. So I just have it there because on the FDA site that they said they were going to do it. But until then, we're still kind of looking at these categories. If it's a category A, it's safe. If it's B, studies have not been done on the humans, but in animal studies, and there was no risk to the fetus. So animal studies looks, you know, so someone might be a little more cautious, but they probably are going to be fine. Their doctor will probably prescribe it. C, studies have not been done on humans or animals, or studies done on animals have shown teratogenic effects. So once it gets to a category C, you're not going to be getting that drug unless it's like risk benefit analysis seriously outweigh, like the mother has to have this drug, like they just has to have it for, you know, their survival or something. And then category D, studies have revealed specific adverse events. So category D, they know there's damage, no question about that. Category X, even more, like X, no. So that's where you're at. So A and B would kind of, you know, be okay, and then C is probably your hard line, but that might depend on the person and what's happening in their specific situation. Okay, so drug interactions. There's a lot of these terms that you see how you feel like they could kind of overlap, like adverse event, drug reaction, drug interaction. So you kind of, I would just write them down, maybe make flashcards and just think of them and try and come up with a situation that sort of seems to overlay to help you. Drug interactions, adverse toxic side effects, when certain drugs are given concurrently with another drug. So the interaction should clue you instantly to, well, it's interacting with something. What's it's interacting with? Well, another drug, an herbal supplement, food, something like that. Okay, pharmacotherapeutics. The drug dose is the quantity of the drug administered. So it's just like milligrams, you know, like the actual quantity of the molecules, how many, you know, how much drug. Loading dose. So this is an important concept. So a high dose of a drug is given initially to rapidly establish a therapeutic effect. And then after you get your loading dose, then there might be a lower maintenance dose. So they ramp you up. That they might do that with pain medication. So say you're in acute pain, you just had an accident, something really painful is happening. They load you up real good. And then they don't keep giving you that super high dose. They give you a maintenance dose. Minimum effective concentration. That's the amount of drug that's required to have some kind of a therapeutic effect. So you may have an effect below the therapeutic concentration, or the minimum effective concentration, I mean, but you're not necessarily going to notice it clinically. So that's going to be like the dose that actually lowers the blood pressure. Toxic concentration is you're not getting a therapeutic benefit anymore. Now you're just getting a toxic effect. So there's a threshold there. There's a threshold that you want to be in. The doctors are trying to prescribe you a medication dose that's in this happy place where you get your therapeutic effect, but not too much, not too little. So that's the therapeutic range, somewhere between minimum effective concentration and the toxic concentration. You don't want it to be toxic, but you want enough to have an effect. So this just demonstrates it. So here you have, like you'll start taking your medication and it'll start, take a couple hours to start working. And then finally, after this is showing, after 2 hours, finally your medication kicks in and you're in the therapeutic range. It might peak at, the 6 hour mark, and then it's going to start to come down, and then it's going to leave the therapeutic range or that minimum effective concentration. And so you would have taken another medication before it dropped out of here. You would have taken another dose, somewhere in here while it still has a therapeutic effect. And they calculate all of that they take into consideration the half-life and all that to calculate the right range. And this is just showing the loading dose. So like drug A, if they gave the same milligrams just out the gate, like you go to the doctors and they're like, here's 12 milligrams or whatever of this medication, and it's like, take it every 12 hours. It's like do. Well, it would take like more than 2 days to start to get to the therapeutic range. This is really important with maybe something that works on neurotransmitters or takes a while to take an effect. Some depression medications, and they might take 2 weeks to actually start seeing an effect. So they might do something like this, maybe, I don't know really, but that's kind of came to mind. Yeah. With antibiotics. Yeah, that's a great example.
They take it in the chair before.
So they take a loading dose in the chair and then you send them home with a smaller dose.
Yeah, well, or they would take it at home before their appointment.
Mm-hmm.
But if they forgot it or they didn't fill it, then you
give it to them in the
But
chair.
hygienists would do that too.
Mm-hmm. I've done that
They
with
were doing
pre-med.
like,
Is that pre-med? Is that what you're thinking of? Or
no,
if they
it
have
was-
infections?
No, it was for like connective tissue grafts. Like
Oh,
it's
after
for-
surgery, after periosurgery.
Before, yeah, to prevent
Mhm. Yes, yeah, Dr. Matsuda would do that too. So that's a great example. So you get them loaded, you get it in their system, and then they maintain that. And you can see how if you do that, if they give a higher dose, they'll have an effect much faster than if they do a smaller dose. It'll take longer to take an effect. Okay, couple more, I think this is the last terminology slides for this one. So potency is the dose or the amount of drug that's required to produce a particular effect. So the potency of a drug, how potent is it? And then efficacy, the ability to produce a therapeutic effect regardless of the dose. So is it efficacious? Is it effective? Does it have efficacy? So there's different ways to say that word, but they all mean the same thing essentially. It's like no matter how much you give, whether it's a potent drug and you give a little, or if it's not potent drug and you have to give a lot, does it have efficacy? Is it effective? Is it going to do what it's supposed to do? Potency and efficacy often describe the success of a drug therapy. So if a drug doesn't actually do what they've claimed that it's supposed to do, it's not effective. It's not efficacious. So, and then the potency is I just watched this whole thing on this new Alzheimer's medication that all the studies show that it really actually doesn't do anything, but they're still trying to sell the drug. So trust me, it can happen. Well, don't trust me. Go find out for yourself. I don't want to tell anyone anything. But it's crazy because sometimes you do realize that there are medications out there like this crazy expensive new Alzheimer's medication that doesn't actually have scientific data to back up that it will do what they claim it does. But anywho, so potency and efficacy. So here's an example. A drug like hydromorphone. Hydromorphone is very, very potent. It would take a very small dose to get a very high therapeutic effect. Something like morphine is less potent because you need more of it to get the same effect. And then something like codeine is even less potent because see, now you need close to 100 milligrams to get the same effect. And then something like aspirin is like even way less potent because you don't even get up to that height with a certain dosage. So that's just an example of potency. So sometimes a little does the same as another drug that you need a lot. Okay, so and oh, I do have a ceiling. Let me see. I have a note here about the ceiling effect. And that basically, and you get that with a lot of narcotics. Talk about the ceiling effect. Therapeutic response cannot be increased with increased dose. So if a drug has a ceiling, you just think of it as a physical ceiling. Once you hit that range, it doesn't matter how much more of the drug you take, you'll never get more pain relief, or you'll never get more whatever. And controlled substances are like that a lot. And I'm sure there's other ones too, but you hit a therapeutic ceiling. You're just not going to get any more pain relief if with whatever drug that you're talking about there. So that, yeah, no.
For the consistency and efficacy, so is it on a little bit about it, potentially, efficacy can be high, or
Yeah, so a drug could be not a very potent drug, but it could still have an effect. It could still have a positive therapeutic effect, even though it's not a very potent drug. And I don't have I should have examples for all of these. That's my to-do list for next year, is I'm going to put in drug examples, because I think it kind of helps when, like Lacey was saying, if you kind of can explain an example of one, I think that helps. I don't have enough of those, but yeah, and then if a drug has high potency, you only need a little bit of the drug, but to see the efficacy of it. So the potency can go up and down. So it can be high potency or low potency and still be effective or have efficacy.
Like a baby aspirin,
Uh-huh.
not very much dose, but it still has a really good.
Yeah, it still thins the blood. So exactly, like you used to take aspirin for pain med, so you take a higher dose for pain med, but now we do the low dose aspirin, so it's still potent for a specific function. So that's a good example. Okay, so we've only gone a half an hour, so I'm not going to break. I'm just going to move on to wait, have we only gone a half an hour? We've gone 50. Oh, crap. Okay, because we have to do blood glucose, and I want to give at least a half an hour for that. So we have 50 minutes left. So I have to keep going because I only have 20 minutes to go to the autonomic. So if you have to go potty, go potty. I have a 4-year-old. If you need to use the restroom, go ahead, but I'm going to keep going. I'm going to keep going because we've got to get to blood glucose, and so I'm only going to do this for 20 minutes max. Okay. Autonomic nervous system. So there's not a lot of slides here, but this section can take a second. And it's only because you're trying to remember, we just learned a few receptors, and you have to remember what those receptors work on. And a couple of them are really easy to remember because there's a mnemonic, there's like, and we'll get to it. It's pretty easy to remember, but a few of them are like, okay, I'll do this again. And so just try and make up some flashcards, and I have an exercise here that you can take home, because I don't think we'll have time to work on it in class. But you can take it home, bring it back, and we'll work on it. We'll go over it together next week after the quiz. So these are the objectives. We're going to talk about the different systems in the autonomic nervous system, the sympathetic and parasympathetic. We're going to illustrate different types of receptors, neurotransmitters in the autonomic, and then describe the differences between adrenergic and cholinergic. Those are different receptors in the different branches. We're going to discuss how agonists and antagonist medications work. So we're kind of harkening back to what we just talked about just now. And then identify common autonomic medications and how they affect the body. So when we talk about the nervous system, we have like these flow charts here, because we're gonna break it down into a couple different sections. So at the pinnacle, we have your central nervous system, which is your brain and your spinal cord. That's your central nervous system. And then we have the peripheral nervous system. So you can think of all the nerves that come off of your spinal cord. That's your peripheral. So central is just brain and spinal cord, and then peripheral is everything else that comes off of it and communicates with your organs. So it communicates with the rest of your body. So of the peripheral nervous system, that branches into two places. You have the somatic nervous system, which is voluntary. I'm going to move my arm like this. That's my somatic nervous system. My brain telling my arm to do that. We're not going to study that at all. So that is just kind of there for you to know. What we will do is drop down to the autonomic, which is involuntary, automatic. This stuff, my heart just beats automatically. It's part of the autonomic nervous system. So with the autonomic nervous system, that branches into two sections. We have the parasympathetic division of the autonomic nervous system, and then we have the sympathetic division of the autonomic nervous system. So that's where we really get into focusing what we're going to talk about is once we get there. We're going to revisit these, but the parasympathetic, those are all cholinergic receptors. All the receptors and everything that we talk about in the parasympathetic are cholinergic receptors. And those receptors get broken into muscarinic and nicotinic. And we don't talk about those as much, except for they have a major effect on salivation. So there's like pretty much one thing that we keep kind of going back to. There's a few things we talk about with parasympathetic and those receptors, but way more of the medications are going to be on the other side with the alpha and the beta receptors. And so that's what we spend more time with. But there are a few key points with anticholinergic medications. So we'll talk about that. But so those are the receptors, muscarinic and nicotinic. And then for the sympathetic, those are all called adrenergic receptors. Adrenergic receptors for the sympathetic. And then those adrenergic receptors that we'll talk about are alpha and beta. And those are further subdivided to alpha 1 and alpha 2, beta 1, beta 2. And there's actually a beta 3, but we don't talk about that really at all. Okay. So for the autonomic nervous system, sorry, I'm just giving myself a timer. So for the autonomic nervous system, like we said, we have the parasympathetic division and the sympathetic division, and they do different things. So your body will automatically react in certain ways during different situations to help deal with different things that come to you in specific ways. Parasympathetic will do things like constrict your pupils. If your pupils are constricted, not as much light comes in, you don't have to see as sharply. Your saliva is going to be stimulated. I should have said this beforehand, but parasympathetic is considered rest and, oh, there it is. I'm like, where's my rest and digest? So parasympathetic is called rest and digest. So anything that seems sort of like comfortable, your body's relaxed, you're going to be more likely to digest food, you're going to feel, it says constricts breathing, which sounds kind of scary, but really what it means is you don't need a ton of oxygen. Like you're not freaking out and running away, so your lungs aren't like, trying to open up to let in more oxygen. So constricting oxygen sounds kind of like nervous really, but it's really just means you're not demanding oxygen. Stimulates saliva, you're relaxed, that's the first part of digestion. And then of course it stimulates digestion and your heart rate is lower. There's other things that are affected too. And we'll see it in the flow chart okay, I've lost my word, but there's a diagram. We'll look at it in a second. Fight or flight is the sympathetic. And a lot of people have sort of had an intro to this, especially if anyone deals with anxiety, they've heard this whole spiel before. But when you're in fight or flight, or when your sympathetic system is activated, then your pupils dilate to let in light. So you see, you react, you're feeling like hyper aware. Your saliva is inhibited. Everything that would be sort of deemed unnecessary. Like, I don't have to digest my lunch. I have to like survive. So saliva tends to dry up because that's the first step of digestion. So your mouth gets dry, your GI system sort of slows, so you don't digest food as well. And this is only supposed to last, theoretically, a very short period of time. But in the modern age, we tend to carry anxiety with us for hours upon hours. So it can create more issues. But your heart rate is increased, you get nervous and your heart starts pounding, and then you breathe heavier, more oxygen. So here you can see these shows specifically what parts of the body are affected and what it's doing. So with the parasympathetic, your pupils constrict, stimulates saliva, slows your heart rate, constricts breathing, stimulates digestion, stimulates the gallbladder. So there's enzymes that are released, and there's other systems that are affected. We just don't talk about it. Contracts the bladder, stimulates the sex organs. Nobody, that's going to happen better when you're relaxed, not when you're stressed. And then sympathetic division, fight or flight, dilates pupils, inhibits saliva. So it's all kind of like opposites, right? It's just sort of like the opposite thing happens. Facilitates breathing, inhibits digestion. So the other thing too that I love, there's these doctors. I don't know if I posted the video. I'm going to post it so you guys. There's these two doctors that explain this stuff so well. And but the video is like 10 minutes, so I'll post it on Moodle and you can watch it if you want. But I don't think it's in my PowerPoint. Okay, so this is all nerves communicating to your eyes and communicating to your lungs and things like that. But how do they actually communicate? And they communicate basically by neurotransmitters. Like, so what we were talking about, endogenous substances, they're in your body, and they're chemicals that cause reactions. So that's the way the neurons communicate. So something might be released more if you're feeling one way, or less if you're feeling another way. So there are chemical substances made in the neurons that are released. And you can think of the neuron sort of as just these long, electrical cords in your body that are just going out to all these other areas, but they're not solid, they're chunked up. And so they're called preganglionic neuron. You have a synaptic area or a ganglion, synaptic ganglion, which is like a microscopic space where the neuron is released and then gets uptake by the now post-ganglionic neuron. And the reason they call it pre and post is because this is the ganglion. One's pre, one's post, one's before, one's after. And so at these junctions, the neurotransmitter is released. It sends like an initiative or a message, and it keeps going, and then it releases more neurotransmitter at the target tissue. The target tissue could be the heart, the lungs, but anything. So here is just another close-up picture. Neurotransmitter reaches the receptor to generate an action potential, or a command, restrict, constrict, soft tissue or whatever, constrict blood vessels or something, whatever the action potential is. Here's the same picture. I don't know why I have it twice. Okay, so the types of neurotransmitters. So basically, we're just going to be taught for this PowerPoint and for a lot of medications, mostly we're just going to talk about acetylcholine or ACH, acetylcholine, or norepinephrine, NE. Those are like the main ones that we're going to talk about for the alpha beta receptors. There are other neurotransmitters that we do talk about when we talk about other drugs. But for our base knowledge, we're just going to keep it pretty much at those two receptors. So other neurotransmitters in the body, epinephrine, dopamine, serotonin, GABA, there's other ones still. But we're kind of going to concentrate on these primary neurotransmitters. So we have our flow chart again, sympathetic and parasympathetic. If it's a sympathetic division, you're going to have both acetylcholine and norepinephrine. And it's going to work on adrenergic receptors, which are the alpha and the beta. So you kind of just have to get this stuff memorized in your head. If it's a parasympathetic division, it's only acetylcholine. That's the only one on the pre and post ganglion is the acetylcholine. Those are cholinergic receptors, muscarinic and nicotinic, like I had mentioned earlier. So you just have to memorize, write this flow chart like over and over again until you're kind of comfortable with what it says right there. You're just going to have questions that are like, the muscarinic receptors are on what division of the autonomic nervous system? Questions like that. Yeah. Yeah, if it's parasympathetic, you're only going to have acetylcholine or ACH. And it's going to work off of the muscarinic and the nicotinic receptors. If it's the sympathetic division, you're going to have ACH and NE, norepinephrine, and it's going to work off of the alpha and the beta receptor. And another term, there's lots of terms that sort of seem to go together, but if it's an adrenergic medication, if it's an adrenergic agonist or an adrenergic antagonist, it's off of the sympathetic division. If it's a cholinergic receptor or an anticholinergic medication, it's working off of the parasympathetic. So that's why you kind of have to know those things. Okay, parasympathetic division, cholinergic receptors, muscarinic, nicotinic, not a ton of medications that we will talk about. In general, a lot of the medications work off of the other division, but muscarinic, it innervates sweat glands, blood vessels, smooth muscle. So there is quite a few medications that work on smooth muscle. Slows cardiac function. So if there is a medication, it's probably going to be working off of the muscarinic receptor, if there is one that we talk about. Nicotinic causes skeletal muscle contraction. They don't find a lot of therapeutic benefit off of this receptor. So that's why there's not a lot of medications that we talk about, because the pharmacology wizards haven't found a lot of therapeutic medication that will benefit skeletal muscle contraction. And that's a big thing of what, and there's other things. I mean, there's a few random things, but that we don't really talk about that. Neurotransmitters, acetylcholine, released from the parasympathetic, preganglion, and postganglion. So that's easy because you just have to remember the one neurotransmitter. It's on the pre and the post. Just have to remember the one. This is the ugliest drawing I've ever done in my life. And if you look at it, you're probably like, what is this? This is the spinal cord. So this little picture here is, I kind of blow it up here and I blow it up here. So here's the spinal cord. I drew it with a mouse. That's why it's so horrible. I swear my art's better than this normally. But so here is the, at the preganglion. So here it's blown up, the preganglionic neuron. We're releasing acetylcholine. And then here's the other side over here, the straight line in the middle. That would be the postganglionic, and it is accepting the neurotransmitters. And then it travels down the neuron, and now the red circle is highlighting, this is the postganglionic neuron, and here's the heart tissue. Because this is a picture of a heart, can you tell? Oh my gosh, really? Yeah.
So is the acetylcholine affecting the blood vessels?
It's giving a message. So yes, it is. Like basically, because it's working on whatever specific receptors it's working on, it's giving a message to do something to blood vessels, do something to the strength of the contracting of the heart. So something like that. It's sending a message, do this, whatever it is. Okay, sympathetic division. So adrenergic receptors, we have alpha and beta, and those subdivisions of the alpha and beta are alpha 1, beta, alpha 1, alpha 2, beta 1, beta 2. There is a beta 3, but it has something to do with fat adipose tissues, and it just doesn't matter. But if you might come across that and be like, why don't we learn about beta 3? Neurotransmitters for the sympathetic are going to be acetylcholine and norepinephrine. So acetylcholine is released from all the pre-ganglionic neurons. So the first ganglion or whatever, the pre, it's going to release acetylcholine to go to the post, and then it's going to travel down that one. And once it gets to the target organ, it's going to release norepinephrine. So norepinephrine is released from most post-ganglionic neurons, which then crosses the synapses and has an effect on the tissue or the organ. Epi is also released. There's always more to it. Just FYI, there's always more to it. This is just kind of your basic understanding for what we need to know for as dental hygienists. And again, basically the same picture, but is showing you that for sympathetic, you're going to have acetylcholine at your first junction, and you're going to have norepinephrine at the second junction where it's at the target organ. So it's basically the same. And you guys, I encourage you to draw figures, draw flow charts so that you can, because it's really limited what you need to know. Like I said, there's more to it, but this is all you need to know, but you need to know it well for the quizzes and exams. So, reproduce this stuff until you get the flow of it. Kind of like with radiology and the flow inside the machine, it's kind of a similar thing. Okay, alpha, for an adrenergic receptor, alpha 1 is located on smooth muscle tissue. So in the heart, there's smooth muscle. Inside the vessels, there's smooth muscle. So smooth muscle tissue. So we don't just think of like our biceps, we think of like blood vessels, smooth muscles, things that contract and dilate. Produces smooth muscle contractions. So blood vessels, sweat glands, eyes, intestines, all of that is smooth muscle. And so if it is an alpha 1 adrenergic agonist, it's going to create smooth muscle contraction. It's going to do that, or dilation, I suppose. Depends. But if it's alpha 2, it's located on postganglionic neurons. It inhibits norepinephrine. So it's going to inhibit the release of that neurotransmitter. And so that function decreases blood pressure. It decreases secretion of insulin. We don't talk about this as much, but there is some specifics when it comes to local anesthetic for alpha 2. Beta. So here's the easier one. So alpha 1, alpha 2 is a little harder. You just have to remember the smooth muscles for alpha 1, and then how it can cause lower blood pressure for alpha 2. But for beta 1 and beta 2, you can think of it this way, because beta 1 predominantly works on the heart, and you can think of it beta 1 heart. It pretty much just works on what you need to know about it, for at least for us, works on the heart. Beta 1, you have one heart. Beta 2, a lot of the receptors work on the lungs. You have 2 lungs. Beta 1, heart. Beta 2, lungs. 1 heart, 2 lungs. So it's kind of sort of a easy, way, or like a mnemonic to help you. So beta 1 located in cardiac tissue increases heart rate and contractility. Beta 2 located in bronchi relaxes uterine and vascular smooth muscles. So there are some blood pressure medications that are selective so that they don't end up causing some of these other reactions as well. Okay, autonomic drugs, agonist, drugs that bind with the receptors to produce an effect, antagonist, drugs that bind with a receptor to block. So this is just sort of reviewing what we talked about already. An agonist substance which inhibits, or a substance which initiates a physiological response when combined with a receptor. It's a drug which imitates the action of the neurotransmitter. So it's a drug that's sort of having the body do more of what it would do if there was more of that neurotransmitter, produces an action or a response. So it causes something. If it's an antagonist, the substance which interferes with or inhibits the physiological action of another. So it's inhibiting, and is a drug that blocks neurotransmitters. So it blocks these endogenous chemicals in our body that would cause some kind of a reaction. and it produces its opposite action or response. So instead of dilating, blood vessels, maybe blood vessels aren't as dilated or, whatever. So it causes the opposite response. Here's that picture that we already looked at. I don't think I need to go over that. Okay, so little bit more, and I know you guys always do, but sometimes there's interesting stuff in my notes. Oh, shoot, I'm at 20 minutes. I still have 4 slides. Okay, I'm just going to go really fast. Parasympathetic nervous system. So like I said, you have the cholinergic and agonists, cholinergic receptors or cholinergic agonists would be muscarinic or nicotinic. If it's anticholinergic, so if it's going to do the opposite, then it's gonna be a cholinergic antagonist. And this really only becomes important because there are a lot of medications that have anticholinergic effects. So a lot of the drugs that we talk about ends up falling in the alpha beta realm, not so much in the muscarinic nicotinic. However, you will see that again and again, anticholinergic effects. And that's going to be dry mouth, dry eyes. You can't tend to like pee and defecate, pee and poo as well. So it's like dry eyes, dry mouth, and then your other functions kind of. So that's anticholinergic, and that's gonna come up. So that's why this is really important. Cholinergic antagonists or anticholinergic. Adrenergic agonists, another name for this. This will pop up on an exam and you'll be like, what the heck was sympathomimetic? I don't remember that term. So just highlight this as another kind of term to learn. If it's an adrenergic agonist, another term for that is sympathomimetic drugs. Sympathomimetic drugs, another term for an adrenergic. An adrenergic means it's part of the sympathetic nervous system. It's either an alpha or beta, works on an alpha or beta receptor, and it's an agonist. It's creating that response. So they call them sympathomimetic drugs. If it's a blocker, if it's an adrenergic antagonist or a blocker, they call it sympatholytic drugs. So these terms are not a lot, but I do think it shows up like on an exam. So just FYI, just highlight it and just kind of go back to it and be like, what was that term again? They're referring to the drugs. It's like that's like the classification of the drug. Directly blocks the alpha or beta adrenergic receptors. Okay, clinical application. So here's just a little example. Epinephrine in local anesthetic. So local anesthetic by itself, adrenergic agonists. This is talking about epinephrine. So it's epinephrine is added to local anesthetic because it is an adrenergic agonist. It stimulates alpha-1, which is on the smooth muscles, and it stimulates beta-2 receptors or smooth muscles and has a strong affinity, much stronger affinity for beta-2. So it more potently acts on beta-2 receptors than it does alpha-1. And that's very true for many drugs. It may work on multiple receptors, but it will have an affinity to one. So you'll get a stronger effect off of that one receptor. So the result, I think this is wrong. I don't think this is talking about epinephrine. I think this is talking about local anesthetic in general, because initially local anesthetic can cause an increase in blood pressure. But ultimately, if you give too much local anesthetic, your patient's blood pressure will drop because of and so that's why we have epinephrine in there, is to constrict blood vessels, right? And to keep it localized. I think this is written funky. So I have to look at this again. But basically, that's basically, you can OD, people are always sort of afraid of epinephrine makes my heart race. Oh, I don't like epinephrine. Well, if you get too much local anesthetic, that's actually worse. Your body produces epinephrine. People can't be allergic to epinephrine. You can have like a racing heart and sort of have a reaction to it, but you can't be allergic to epinephrine because we have it in our bodies. So a lot of times patients don't understand that, and it's a safety thing really in a lot of ways. Of course, there are people with bad cardiac conditions that we have to be cautious, and there's cautionary reasons to not just throw epinephrine at everyone all the time. But local anesthetic in itself can actually lower blood pressure. Okay, worksheet, I'm gonna hand that out. Encourage you to make flashcards on this. This is sort of an example of how to make flashcards. But we're gonna pause this for now. I will come back to this at the beginning of next class for questions, and we'll do this worksheet together. But what I wanna do in the next 20 minutes, you guys, you have to hurry, is to take blood glucose. What you're gonna do is I'll pass this stuff out. I have to go get the glucometers. They're in clinic, and I'm gonna get masks and gloves. So in the meantime, come up and pair up and take a couple, one or two Band-Aids, one Lancet. I will pass out these and a little alcohol. I'm gonna go get the other stuff. Do you want me to come with myself? Little. I can, yeah. Oh, but the mask. Yeah, I'll come with. Okay. That's it tomorrow. Two of everything. Two of everything. Two of everything. What? You need a second, is it? Okay. I don't have a second. I'm just kidding. You don't have one? Yeah. Yeah. Test. Partner. More bonds. Okay. You're getting over. Yeah. Hold on. Yeah, go. Yeah, so like right on the side, like hold it. Might be a little hard for me. Yeah, for me. I know, like, why are you gonna be high? I don't know. I'm fine with like that. So is here's the biggest problem. This is why it takes a ding long. If we have four of these, we're never gonna, okay, here's what I'm gonna do. If you guys, if you guys don't get to it, if you want, I will be in here at lunch. If you wanna do it at lunch, I'll be in here at lunch. Okay, so I'm just gonna put one, just gonna try and spread these around. See? Here's the thing. This is what I want you guys to be aware of, because even though this is not at all going how I wanted it to go, so we're on time. When you have the glucometer that I just only had 4 of that I passed out, when you have the glucometer and you take this little tab here, if you shove this part that looks like a circuit, whatever, like a microchip, whatever, when you insert that into the glucometer, if you push it all the way back, it turns it on and it starts asking for blood, but it times out very quickly. So if you stick it all the way in there and then you start fumbling to get blood, it'll just error. And then you'll be like, oh, shoot, an error. And it's good that you practice it and you find that can happen now. That's good. And it happens in the clinic. I just want you to know why it happens. So if you put this in, and you kind of will feel it catch a little bit, but it won't like turn on the machine. That's a good place for it to be, because it's in there. So once you've gone and gotten the blood sample, then you can put it, you can see there's like, I'll pass these out, but there's a little slit at the end. And you just put that up to the little blood pearl and suck it up in there. And then push it into actually you'll have, by that time you will have pushed it all the way in. So you push it all the way in once you have the little blood pearl, then you bring it up, suck up the little blood pearl, and then it'll start recording the number. So, and when you use your Lancet, use it and then wipe it once with alcohol. That'll like take off that first little bit of blood that comes to the surface, and I feel like it makes the blood come out better. So I'm gonna bring these around here. If you need another one. I'm so sorry that you're only
No, there's no one saying there, it's just these two. This is something extra. Okay, so the professor is like. And on the side, because on the pad itself is gonna hurt the user. You could, what, something like. Because I used to have to do something like this, just. Shake your hands. Take that in, yeah. So, that. He's doing it, babe. Would it be easier if you turned towards her? Okay. Looked away? Yeah. Okay, listen, I never worn. Oh, so our computer is right there for all of that. Or at least for the needle. Yeah.
Oh, yeah.
You know, that one over there. And then it's they have one. I think a lot of them are-
Taken like a while ago, and I saw her flood.
You want to put on
Almost.
all the way around.
Dude, that's kind of twice.
Oh, and you had so much blood?
Yeah, it was like dripping down my finger. I was like, is this normal?
That's way more.
Never on my head, that. Oh, and. $71. You remember that? I don't remember. That's not fun. Versus 95, there's 71. You have.
A hundred, no good. That's correct.
I just remember when the limits are. Or. Oh, yeah.
With cold.
Taking longer now.
171. I know, sometimes when you're reading it's really low, you're like. "Ooh, I didn't get the picture."